to this week's Cancer Center Grand Rounds. We have two speakers today, both from Yale. Will give us some exciting discussion of some of the work we're doing here. Our first speaker is Mario Strazzabosco. He's a professor of medicine, director of the liver cancer program here, and co-director of the Yale Liver Center. He received his medical and PhD degrees in Italy and then had a number of leadership positions at the University of Milan before joining our faculty. He's an expert on the care of patients with liver cancer. He's internationally known for his work in hepatology, liver transplantation, and is a member of several scientific societies in Europe and the United States. His current research relates to the pathophysiology of biliary tract diseases, biology of liver repair, liver transplantation, liver cancer, and healthcare management. And so today we're going to hear from Mario, and the title of his talk is Liver Cancer Clinical Care and Research at Yale. So Mario, you're up.
Thank you very much, Dan, for the introduction, and thanks for the Cancer Center for the invitation, and thanks a lot to the Smilow Cancer that the program has received during this year. I'm really only as a spokesperson for a group of colleagues that are interested in liver cancer and treating liver cancer. So I'm just a messenger. So what do we do in the liver cancer program? We take care of patients with liver masses, either benign or malignant. And the two most frequent primary liver cancer are hepatocellular carcinoma, also called HCC, and intrahepatic cholangiocarcinoma. And I focus my talk today mostly on HCC, which is the most important primary cancer of the liver. The liver is an organ which is located in the abdomen, but really here it is the main regulator of the whole body metabolic homeostasis. And in fact, if the liver fails, we actually, the patient suffer of a syndrome, which is it's absolutely a polysystemic syndrome, as you can see here. And the important thing to understand is that 85% to 90% of the patient with hepatocellular carcinoma, they are also cirrhotic in the liver. And not only that, but if we follow a cohort of patients with viral induced liver disease, either B or C, for enough time, we see that when they die, most of them, they died with an hepatocellular carcinoma, as shown here. So why the hepatocellular carcinoma is actually on a rise worldwide, and the estimate are that there are 830,000 cases recorded every year, with a mortality that almost approach the incidence. And why is that? Well, this is the result of a number of worldwide epidemics that are also risk factor for chronic liver disease. And among them, we can mention viral hepatitis, B and C. You see that the infection from viral hepatitis is hundreds of millions of people. Alcohol is another important worldwide risk factor, as it is obesity, diabetes. And more and more we realize that a fifth important risk factor is due to inequalities and population that are underserved, and they have difficulties in reaching and being reached by the best care. Other risk factors, smoking, aflatoxin, and other as well. And it is important to understand that the combination of risk factor increases exponentially the risk. So in every patient that we see, we need to look for all of them. These risk factors are distributed unequally in the worldwide. For example, aflatoxin is more frequent as a cause in the African continent. But if we go to the US, although this publication shows NASH as a main factor, it is actually, we have all the risk factor combining here, because we have NASH, we have alcohol, we have hepatitis C, and so on. And in fact, if we look at the distribution of the incidence of HCC in the US, we see that it's actually particularly high, about 8 per 100,000 in the Massachusetts, Connecticut, and New York. So if we look more in depth into it, we see that in the US, the liver cancer incidence has increased almost 3 times in the last 30 years, and the mortality is increased almost 2 times, as shown also in this graph on the right. If we look at the numbers and compare the number with 2 big GI killers in the digestive system, like pancreas and colon, we see that in Connecticut, we have a record of 480 cases per year. And this is a combination between HCC and intrahepatic cholangiocarcinoma, although the intrahepatic cholangiocarcinoma is really minority. So we have 480 new cases and 320 deaths, unfortunately. And this is a figure which is similar to another big killer, like the pancreatic cancer, 730 and 520. So how is the molecular pathogenesis of hepatocellular carcinoma? We have said that most of the patients have cirrhosis, and in fact, the main theory is that in the cirrhotic nodule, there are events that happens that brings to cholangiocarcinoma and hepatocellular carcinoma, and one of these is the altered TRT promoter that basically blocks the ability of the liver cell under inflammation to undergo senescence. And among them, there are other possible pathogenetic event like P53, which is basically associated with aflatoxin, beta-catenin mutation, and so on and so forth. But this is a scenario that is not very well understood. All we can say for now is that there are 2 different classes, one named proliferation, the other non-proliferation, that are different in terms of their prognosis and in terms of their ability to respond eventually to immunotherapy. So hepatocellular carcinoma is a very peculiar cancer because it has a dual personality. It's a cancer in a failing vital organ. And it can be seen from a biological perspective. There are inflammation-induced phenomena, oncogenic viruses, and heterogeneous mutational landscape. And this brings to a complex tumor phenotype which is aggressive. It is heterogeneous with a high recurrence rate. Whereas from a clinical point of view, we have a neoplastic disease and the liver disease. And so the treatment strategy has to be tailored according both to the tumor stage and the functional stage of liver disease. And this creates some of the peculiar things in the management of this disease. So we don't have one single way to manage it. We have resection, ablation, chemoembolization, radiation therapy. Systemic therapy still has a growing but still small role. We have the possibility to transplant the patient, the only solid organ that can be transplanted. And most of these patients actually die because of liver failure. And in fact, one professional figure that is involved in this is the hepatologist. Because of all these different professionals involved in the treatment, the entry points usually are multiple. And these multiple entry points in the system creates different trajectory for the patient with dispersion of resources, and can impact on the outcome because there is a confusion and you don't really know what the pathway the patient should follow. And this is one of the reasons why it is important to have a teamwork. So to give an example, probably it will take the whole day to this guy to figure out how to change the tires, whereas the Formula One team can do it exactly in 2.5 seconds. Which is amazing. And this is the result of the coordination of care. So treatment of hepatocellular carcinoma needs coordination of care. And this is the trajectory that the program has followed through the years. So we started as a conference, and I remember these few people, with me, Ron Salem, Jeff Pollack, Jeff Wainreb, Dan Pat, starting this little room. And then it grew to a tumor board, thanks to Tamar Tadi. And then now it's becoming a program, and maybe it's ready for the next step. So when it became a program, we designed an ideal structure, which is the patient can come into the system through a single point, still working on that aspect, and then is actually discussed at the tumor board where the treatment allocation happens, and is allocated to the different specialty according to the best treatment. And after that, it gets follow-up because we need to treat the risk factor, we need to mind the liver health, some chemoprevention protocols, and mirroring this clinical operation, there is also a research component, which is, again, a team effort. So where are we? So we begin with this is a map of the Smilow Care Center, okay? And this is the two main sites for liver care here at Yale New Haven Hospital and the VA hospital. But through the recent year, there was open a site in Bridgeport with Mike Netterson, a site in Danbury, Kim To, Stanford, Mike Shinsky. Jan Battisti is on the westerly side, and soon Ariel Jaffe will go to Westford. Now, this is in combination with the transplant team, with which we have a very good, long-standing collaboration. Now, it really takes a village to treat this cancer, and here you can see not all of the colleagues that participate, and I have to say it's a real privilege to be able to work with these individuals, and they are extremely skilled. All of them are leaders in their own right, in their own field, and so the discussion that we have are so enlightening, and we follow like a structured discussion going through analyze the resection, the transplant candidacy, or whether we need to use local regional treatment like ablation, chemoembolization, radiation. I don't have the time to go into this, but it's every single of this possible treatment is very complex, and the decision making is even more complex because it depends from systemic and local factors. And in fact, we basically follow the Barcelona liver cancer treatment, which is used by most liver societies, but it really has a lot of troubles, okay? There are changes. This is the latest version and takes into account liver function, performance status, and the anatomic location of the cancer, but really there are a lot of troubles. And we cannot be so strict with the categories. And for example, this was written in 2019. Now the first line treatment is atezolizumab, but cannot be only confined to patients that are about to die, as in this staging system. So a lot of things are changing, and are made difficult by the fact that we have multiple etiology, the underlying liver disease, the frequent comorbidities. In fact, this is a cancer that peaks above 65 years of age. We have multiple treatment options, and 70% of them have a recurrence of the cancer in the next 20 months. We have liver transplantation and other actors. So the only way to maintain a structured approach to this is to the tumor board, which for us is not the way where we present strange cases, is really the machine. And the credit for this goes to my colleague and friend, Tamar Tadi, who set it up. And now we discuss 13 cases each week. Last year, even with the COVID, we discussed 520 cases, and one of the busiest, actually, tumor board. 200 of them were new cases. We have 300 patients in follow-up, 130 new cases. And these actually are treated in several different ways, but this is not the venue to go through the volumes, although they are substantial. The tumor board is also where we got ideas for research and ideas for improvement and innovation. This is the list of items that we discussed at the last steering committee, for example. Several of these questions that I'm not going to read all of them, but generate research opportunities and also great care. I want to go briefly through this case. This was a patient referred to Dr. Shishki for transplant evaluation. Mike saw the patient, realized that he had actually liver cancer and and had infiltrative hepatocellular carcinoma with the tumor portal vein thrombosis. So we discussed the case at the tumor board, and it was decided that there was no other option rather than medical treatment or offering a trial. Stacy did try to give him sorafenib at the beginning, but this was denied by the insurance. And so it happened that Stacy had just opened a trial, the initial trial with the Tizo Bev, which is now, the first line treatment. But back in that time was actually, we were very lucky that we could offer him. And as you see here in the graph plotting the alpha fetoprotein, he had a complete response. But in the next 2 years, this patient was completely, the quality of life of this patient was completely altered by recurrent severe episodes of portosystemic encephalopathy, as you can see here from the ammonia. And actually, during one of these admissions, also a discussion about goal of care was initiated. So we had a patient that was treated by the from this malignant tumor, but he was dying because of liver disease. And at that point, two very bright hepatologists, one a gastroenterologist, which is Tamar, and another is Todd Slachter, which is an interventional hepatology, I call him, decided to embolize his planorenal shunt. And now the patient is functional, cancer-free, happy. And when he refers to what happened with the insurance, he quotes Winston Churchill saying, "A pessimist sees difficulties in every opportunity, an optimist sees opportunities in every difficulty." So this is a case which we learn a lot about it. And in fact, now, particularly, one of the things that was interesting in the Gary case was that he never had a recurrence. And whereas a recurrence is something that plagues our patients, 60–70% of them in the first 2 years. So that prompted the opening of a trial again by Stacy. And this trial will actually try to address the role of adjuvant treatment after surgery or ablation. Another trial is being brought here by David Madoff, who actually addresses another nuances of this. So his aim is to understand whether there is a benefit in what we call combination treatment. So the idea to combine chemoembolization with immuno-oncology in combination with the TKI. And another important aspect of the program is the fact that we really try to record and measure the outcomes. Ariel Jaffe with John Onofre, Moritz and Giulio Shapiro, they are curating a database of 1,000 patients in a year, and the survival curve divided by BCSC stage that you see here are our own outcomes. So we can really make determinations that are based on our environment and expertise. And as you see, for example, that the outcome is outstanding up to more than 3 years, for example, in patients with initial cancer. Things are changing after this, and there's a lot to be discussed among these patients. And I don't have it here, but if anybody has a doubt about transplantation, I can tell you that the curve of transplantation is like this. So outstanding long-term result for the few patients that can get it. But this is a very important aspect of what we do. And it's going to be so complex that, in fact, Julius with Jim Duncan, Mindley, and John are actually very much involved in trying to understand the use that we can have of artificial intelligence in the diagnosis, characterization, and treatment of this cancer. And we expect that this would be a great aid to our decision-making and also discovery of new approaches. So what the liver cancer program doesn't have a formalized research program, but is actually the assembly of several different interested people. What have we done to put together these people? So the first thing that we have been doing with Julius Tamar is these liver cancer talks. They're monthly in the late afternoon on a Thursday, each of them with 2 or 3 presentations. This has to be ongoing research, not published work. It covers all the aspects, clinical, translational, healthcare. And this approach sparked collaboration. There were paper, grant application, and also a big step forward was last October, when, again, with the help of Tamar, Amy Justice, and thanks to the help of Gary Honeycutt and his team in the Cancer Center, we put forward the first liver cancer summit, which is called Prelude because it was not in person, it was virtual, but the mission was to address the oncologic challenges of liver cancer to the collaboration among of a wide spectrum of Yale faculties. And I'm going to really run through some of this research aspect and in what I call the Commonwealth of liver cancer research at Yale, okay? Because it's not, again, a formalized structure, but it's the gathering of interested people coming from the medical school, the School of Public Health, the VA system, involving departments like surgery, internal medicine, the Cancer Center, the Yale Liver Cancer, the Department of Pathology, and so on and so forth. But all these people actually, in 2019 and 2020, published 72 papers, and 38 of them are original articles, 7 are position paper, 14 are reviews, and 14 of them are actually published in journals with an impact factor around or above 20, which I think is pretty remarkable. So just very quickly glancing through it, a number of our faculties are actually involved in studying the different risk factors that I mentioned before. So we have outstanding work performed on viral etiology, interaction with aging, the HIV. We have a full program that addresses the obesity, diabetes, and NAFLD. Alcoholic liver disease is another research branch which is growing, and also healthcare disparities. And for example, Reza Rossi and other faculties are addressing some of the differences that we see even in Connecticut. So for example, as you can see here, the incidence of HCC is clearly higher in the Hispanic and Black population, and hopefully we'll try to nail down what the causes are. Outstanding research in outcome research, mostly addressing the role of surveillance and the role of antiviral treatment. And the growing group of faculties are also interested in cost effectiveness and care delivery. We do a lot of things, but we don't really know their value in terms of cost effectiveness. So this is another growing area. Translational studies are also growing, and just to mention, several faculties in more basic studies are interested in the transition between NASH, cirrhosis, and cancer, and immune enhancer, and a lot of people is actually interested in the role of the tumor microenvironment, which this is, I think is very interesting. This is staining for alpha-SMA, identifying fibroblasts, cancer-associated fibroblasts in cholangiocarcinoma and in hepatoma. You see 2 very different pathology, and these are correlated to 2 very different aggressiveness also the tumor. Let me very briefly mention some of our work in the microenvironment of the cholangiocarcinoma, showing the central role of CAF, of cancer-associated fibroblast in determining several of the aspects of the tumor. And now our other colleagues are addressing this using single-cell transcriptomics. This is also an interest of our colleagues in radiology. They're trying to use the tools of radiology to generate reliable imaging biomarker for immunotherapy. This is, I think, it's granted or proposed for the NIH by David Madoff and Jean Duncan. Interest on the metabolic aspect is also followed by Mike Nathanson lab. And here is work from Mateusz Guerra and Mike Nathanson looking at the IP3 receptor and mitochondrial functionality in HCC and CCA and their role in chronic effect like resistance of apoptosis or generation of apoptotic factor. This was published very well last year. And finally, mentioning Chen Liu, who just joined as a chair of pathology. He's a very well-renowned liver cancer researcher, and he's doing several things. Among this, he is planning to detect circulating methylated DNA as an early diagnosis of HCC, and we're really looking forward very much to these studies. And also he is trying to is using CAR-T and glypican-3 as a target for immunotherapy of HCC. And I'm going to finish now because the time is over. But this is just an example of the richness of the research that we have. And really, this is, and I have to thank all the departments that are involved in this enterprise. And in each of these departments, there are some hepatologists hiding there. And this is what I call Yale Liver, which is a very old tradition here, is going to celebrate the Diamond Jubilee next year. And I thank you for your attention.
Thank you very much, Mario. Very interesting talk. Are there any questions from the audience? I can start with one. So recently, drugs have been developed that will cure hepatitis C virus. What fraction of people in this country of infected people are being treated by these drugs, and what's the effect on liver cancer?
So the strategy would be worldwide eradication of HCVs, and therefore I would say that a growing amount of patients is being treated, should be treated, that has had like a slowing down during the COVID crisis, but should resume full time. The question of the effect on liver cancer is a very good question, because there has been a great controversy because a lot of patients after eradication of the virus have the bad surprise that the liver cancer happens anyway. This is happening in patients that were treated already with significant fibrosis in their liver. And it was initially proposed that actually the eradication of the virus would get rid of some kind of beneficial inflammation. But further studies have shown that actually the risk is decreased, but it's not zero. So why it's not zero is something that we need to understand. My personal opinion is that we are simply eliminating one of the many risk factors. The regular guy is a guy that didn't know to have hepatitis, is a little overweight, has smoked, is drinking, not drunk, but enjoying the wine, and he just doesn't know it. And therefore, here you have 4 risk factors, of which you eliminate one. This is why this is an internal medicine disease, right? Because you really have to address all the risk factors in every single patient. Otherwise, you may fail, like the eradication of hepatitis C shows in certain patients. And so the basic clinical recommendation is that a patient that you have eradicated while he was cirrhotic still needs to undergo the 6 months screening and surveillance for HCC.
Perfect. Are there other questions?